Okay, today we are talking about the patient with psychotic symptoms. So let's start with case summary as usual. Mr. PP, aged 23 years, is assessed by his general practitioner because his family had become concerned about his behavior. Over the last 6 months, his colleague attendance had been uncharacteristically poor, and he had terminated his part-time work. He had also become increasingly reclusive, spending more time alone in his flat, refusing to answer the door or see his friends. After some inappropriate suspiciousness, he allowed the GP into his flat and then disclosed that government scientists had started to perform experiments on him over the last year. These involved the insertion of an electrode into his brain that detected gamma rays transmitted from government headquarters, which issued him with commands and planted strange ideas in his head. When the GP asked how he knew this, he replied that he heard the man's voices. He hears the men's voices as clear as day, and that they continually commented on what he was thinking. He explained that his suspicion that all was not right was confirmed when he heard the neighbor's dog barking in the middle of the midnight. In the middle of the night. At that point, he knew for certain that he was being interfered with. Prompted by the GP, Mr. PP also mentioned that a man is in his local pub knew of his plight and had sent him a covert signal when he overheard the man conversing about the dangers of nuclear experiments. He also admitted to receiving coded information from the radio whenever it was turned on. Mr. PP found his experiences very disrupting and had been considering suicide to escape his situation. The GP found no evidence of abnormal mood, incoherence of speech, or disrupted motor function. Mr. PP denied use of recreational drugs and appeared physically well. After the GP discussed the case with a psychiatrist, Mr. PP was admitted to a psychiatric hospital for a period of assessment and to manage his risk to himself. Mr. PP agreed to a voluntary admission, and as he was now afraid of staying alone at home. We will discuss that later, inshallah. So, the patient with psychotic symptoms can present in many varied ways. It is often very difficult to elicit and describe specific symptoms when a patient is speaking or behaving in a grossly disorganized fashion. Therefore, it is important to approach the assessment in a logical and systematic fashion, as well as to have a good understanding of the psychopathology involved. Definitions and clinical features. The term psychosis refers to a mental state in which reality is grossly distorted, resulting in symptoms such as delusions, hallucinations, and thought disorder. However, patients with schizophrenia and other psychotic disorders often have other symptoms too, like psychomotor abnormalities, mood or affect disturbance, cognitive deficits, and disorganized behavior. There are many classifications that attempt to describe all the symptoms seen in schizophrenia and psychosis, but it is useful to approach psychopathology using 5 somewhat interrelated parameters. 1. Perception. 2. Abnormal beliefs. 3. Thought disorder. 4. Negative symptoms. 5. Psychomotor function. Perception, beliefs, thought disorder, negative symptoms, and psychomotor function. Let's start with perceptual disturbances. Perception is the process of making sense of the physical information we receive from our sensory modalities. Again, this is perception. It is the process of making sense of the physical information we receive from our sensory modalities. So, hallucinations are perceptions occurring in the absence of an external physical stimulus, which have the following important characteristics. So, that's the definition of hallucinations. The perception occurring in the absence of an external physical stimulus. We have these characteristics. To the patient, the nature of hallucination is the same as normal sensory experience. It appears real. Therefore, patients have little insight into their abnormal experience. They are experienced as external sensations from any one of the sensory modalities: hearing, vision, smelling, taste, or touch, and should be distinguished from ideas, thoughts, images, or fantasies which originate in the patient's own mind. Another thing about hallucinations, they occur without an external stimulus and are not merely distortions of an existing physical stimulus, like these distortions called illusions actually. According to which sense organ they appear to arise from, hallucinations are classified as auditory, visual, olfactory, gustatory, or somatic. Special forms of hallucinations will be also discussed. So here we have a figure for an outline of the classification of hallucinations. So we have auditory hallucinations, visual, somatic, olfactory, gustatory, and other special cases. For auditory hallucinations, we have elementary hallucinations, which are some sounds, and we have complex hallucinations. Complex hallucinations may be like hallucinations as first person, second person, or third person. Visual hallucination. Somatic hallucinations could be superficial, tactile, haptic, or thermal, or hygric, and so on. We have visceral somatic hallucinations, and we have kinesthetic somatic hallucinations. We have, of course, olfactory hallucinations and gustatory hallucinations, and other special cases like when we are talking about the place, or it's extra campaign hallucinations or intra-campaign hallucinations, functional reflex hallucinations, and we have hypnopompic and hypnagogic hallucinations. I think we have some details in somewhere else. Illusions are misperceptions of real external stimuli, like in a dark room, a dressing gown hanging on a bedroom wall is perceived as a person. Illusions often occur in healthy people and are usually associated with inattention or intense emotional state, like situational anxiety. Pseudo-hallucinations are perceptual experience which differs from a hallucination in that it appears to arise in the subjective inner space of the mind, not through one of the external sensory organs. Although experienced in internal space, pseudo-hallucinations are not under conscious control. For example, someone hearing a voice inside their own head telling them to harm themselves, or someone experiencing distressing flashbacks in a post-traumatic stress disorder. These are not viewed as true psychotic experiences, though. Okay. Note that some psychiatrists define pseudo-hallucinations to mean hallucinations that patients recognize as false perceptions. That means they have insight into the fact that they are hallucinating. The former definition is probably more widely used. About auditory hallucinations, so let's talk about them one by one. Auditory hallucinations, these are hallucinations of the hearing modality and are of the most common type of hallucinations in clinical psychiatry. Elementary hallucinations are simple, unstructured sounds like whirring, buzzing, whistling, or single words. This type of hallucination occurs most commonly in acute organic states like epilepsy, migraine, delirium, while complex hallucinations occur as spoken phrases, sentences, or even dialogue that are classified as audible thoughts, first person. Patients hear their own thoughts spoken out loud as they think them. When patients experience their thoughts as echoed by a voice after they have thought them, it is termed thought echo. Another kind, second-person auditory hallucinations. Patients hear a voice or voices talking directly to them. Second-person hallucinations can be persecutory, highly critical, complementary, or can issue commands to the patient, command hallucinations. Second-person hallucinations are often associated with mood disorders with psychotic symptoms, and so will be critical or persecutory in a depressed patient or complementary in manic patients. That means mood congruent hallucinations. Third-person auditory hallucinations. Patients hear a voice or voices speaking about them, referring to them in a third person. This may take the form of two or more voices arguing or discussing the patient among themselves, or one or more voices giving a running commentary on the patient's thoughts or actions. Hints and tips. Particular types of auditory hallucination are highly suggestive of schizophrenia, are shown as first-rank symptoms. Here we have a book that talk about them. We have these Schneider's first-rank symptoms of schizophrenia, like delusional perception, delusions of thought control, insertion, withdrawal, or broadcast, delusions of control, passivity experiences of affect, feelings, impulse, volition, and somatic passivity, influence controlling the body, and hallucinations like audible thoughts, first person or thought echo, voices arguing or discussing the patient, or voices giving a running commentary. So we have delusional perception, delusions of thought control like insertion, withdrawal, broadcast, delusions of control, and hallucinations. Okay, so let's talk about visual hallucinations. There are hallucinations of the visual modality. These are the hallucinations of the visual modality. They occur most commonly in organic brain disturbances like delirium, occipital lobe tumors, epilepsy, and dementia, and in the context of psychoactive substance use like LAD, miscellaneous, petrol glue sniffing, alcohol hallucinosis, and so on. An otoscopic hallucination is the experience of seeing an image of oneself in external space. This is an otoscopic hallucination. Charles Bonnet syndrome describes the condition where patients experience complex visual hallucinations associated with no other psychotic symptoms or impairment in consciousness. It is usually occurs in older adults and is associated with loss of vision. This is Charles Bonnet. Lilliputian hallucinations are hallucinations of miniature people or animals and are associated with alcohol withdrawal. What about somatic hallucinations? These are hallucinations of bodily sensation and include superficial, visceral, and kinesthetic hallucinations. Superficial hallucinations describe sensations on or just below the skin and may be tactile, haptic, when you experience of the skin being touched or pricked or pinched. This is tactile. Formication is the unpleasant sensation of insects crawling on or just below the skin. It is commonly associated with long-term cocaine use. We call them cocaine bugs, and alcohol withdrawal. We have thermal superficial hallucinations. These are false perceptions of heat or cold. We have hygric, which is false perception of fluid. For example, I can feel water sloshing in my brain. So hygric. So we have tactile, thermal, and hygric. We have visceral hallucinations. Visceral hallucinations describe false perceptions of the internal organs. Patients may be distressed by deep sensations of their organs, throbbing, stretching, distending, or vibrating. Kinesthetic hallucinations are false perceptions of joint or muscle sense. Patients may describe their limbs vibrating or being twisted. The fleeting but distressing sensation of free falling just as one is about to fall asleep is an example that most people have experienced. This is hypnagogic hallucinations. We will talk about them. Olfactory and gustatory hallucinations. These are the false perceptions of smell and taste. They commonly occur together because the two senses are closely related. A classic example is mood congruent hallucinations of rotting flesh or burning in depression. However, in patients with new olfactory or gustatory hallucinations, it is important to rule out epilepsy, especially of the temporal lobe, and other organic brain diseases. Here we have a red flag. If a patient presents with visual, olfactory, or elementary hallucinations, consider the possibility of brain disorders such as delirium, migraine, epilepsy, or cancer before attributing these symptoms to a primary psychiatric disorder. So we are talking about any hallucination other than auditory hallucination, of course. Special forms of hallucination. We have hypnagogic hallucinations. These are false perceptions in any modality, usually auditory or visual, that occur as a person goes to sleep. This is hypnagogic. Go to sleep. Go to sleep, you can. Okay? Remember it like this. Hypnagogic, going to sleep. Whereas hypnopompic hallucinations occur as a person awakens. These occur commonly and do not indicate mental disorder. Another special form of hallucination, we have extra-campaign hallucinations. Extra-campaign hallucinations are false perceptions that occur outside the limits of a person's normal sensory field. For example, a patient describes hearing voices from 100 miles away. Patients often give delusional explanations for this phenomenon. Another special case, this is functional hallucination. A functional hallucination occurs when a normal sensory stimulus is required to precipitate a hallucination in that same sensory modality, like voices that are only heard when the doorbell rings. This is functional hallucination, while a reflex hallucination occurs when a normal sensory stimulus in one modality precipitate a hallucination in another one. For example, voices that are only heard whenever the lights are switched on. Functional and reflex. So, that was about perception. Let's talk about beliefs. Abnormal beliefs. Abnormal beliefs include primary and secondary delusions and overvalued ideas. So let's start with delusions. A delusion is an unshakable false belief that is not acceptable by other members of the patient's culture. It is important to understand the following characteristics of delusional thinking. To the patient, there is no difference between a delusional belief and a true belief. They are all the same experience. Therefore, only an external observer can diagnose a delusion. A delusion is to ideation that an hallucination is to perception. So it is to ideation as the hallucination to perception. Both have the quality of reality to the person experiencing them. The delusion is false because of faulty reasoning. A man's delusional belief that his wife is having an affair may actually be true. She may indeed be unfaithful, but it remains a delusion because the reason he gives for this belief is undoubtedly false. Like, she must be having an affair because she is part of a top secret sexual conspiracy to prove that he is homosexual. A delusion is out of keeping with the patient's social and cultural background. It is crucial to establish that the belief is not one likely to be held by the person's subculture group. For example, a belief in the imminent second coming of Christ may be appropriate for a member of a religious group, but not for a formerly atheist middle-aged businessman. It is diagnostically significant to classify delusions as primary or secondary, mood congruent or mood incongruent, bizarre or non-bizarre, according to the content of delusion. Primary delusions, we call them autochthonous delusions. Autochthonous delusions. They do not occur in response to any previous psychopathological state. Their genesis is not understandable. They may be preceded by a delusional atmosphere, mood, where patients have a sense that the world around them has been subtly altered, often in a sinister or threatening way. In this state, a fully formed delusion has not developed and patients appear perplexed and apprehensive. Note that when a delusion occurs after a delusional atmosphere, it is still regarded as primary. The delusional atmosphere is probably a precursor to the fully developed primary delusion. A delusional perception is also a primary delusion and occurs when a delusional meaning is attached to a normal perception, like a patient believed he was a terrorist target because he heard an airplane flying in the distance. Primary delusions occur typically in schizophrenia and other primary psychotic disorders, while secondary delusions are the consequences of pre-existing psychopathological state, usually mood disorders. Many interrelated delusions that are centered on a common theme are termed systematized delusions. These are secondary delusions. In mood congruent delusions, the content of the delusions are appropriate to the patient's mood and are commonly seen in depression or mania with psychotic features. What about bizarre delusions? Bizarre delusions are those which are extremely implausible. So the belief that aliens have planted radioactive detonators in the patient's brain and so on. They are considered to be characteristic of schizophrenia. Next, we will talk about a table that lists the classification of delusions by their content. It is important that you can label a delusion according to its content. So, take some time to familiarize yourself with this table. Okay, so here we are talking about classification of delusions by content. The classification and the content. Okay. We have persecutory delusions. False belief that one is being harmed, threatened, cheated, harassed, or is a victim of a conspiracy. Grandiose delusions. False belief that one is exceptionally powerful, including having mystical powers, talented, or important. Delusions of reference. False belief that certain objects, people, or events have intense personal significance and refer specifically to oneself, like believing that a television news reader is talking directly about one. Religious delusions. False belief pertaining to a religious theme, often grandiose in nature, like believing that one is a special messenger from God. Delusions of love or erotomania. False belief that another person is in love with one. Commoner in women. These kind of delusions are commoner in women. In one form, termed Declarambo syndrome. Okay. A woman usually believes that a man frequently older or of higher status is in love with her. Okay. Delusion of infidelity. We call it morbid jealousy or Othello syndrome. False belief that one's lover has been unfaithful. Note that morbid jealousy may also take the form of an overvalued idea, that is, non-psychotic jealousy. What about delusions of misidentification? We have Capgras syndrome and we have Frigoli syndrome. Capgras syndrome believes that a familiar person has been replaced by an exact double, an imposter. Believe that a familiar person has been replaced by an exact double, an imposter. While Frigoli syndrome, I believe that a complete stranger is actually a familiar person already known to one. Okay. So Frigoli, familiarize yourself with someone stranger. Frigoli, familiarize. Capgras, the opposite. Nihilistic delusions. We will talk about Cotard syndrome later on, but in general, nihilistic delusions, false belief that oneself, others, or the world is non-existent or about to end. In severe cases, negation is carried to the extreme, with patients claiming that nothing, including themselves, exists. Somatic delusions, false belief concerning one's body and its functioning. For example, that one's bowels are rotting. Also called hypochondriacal delusions, to be distinguished from the overvalued ideas seen in hypochondriacal disorder. What about delusions of infestation? Ickbom syndrome. False belief that one is infested with small but visible organisms may also occur secondary to tactile hallucinations. Formication. So formication is about tactile hallucination. Delusion of infestation, this is delusion, delusion, Ickbom syndrome. Hallucination, formication, delusion, infestation. Another kind, delusions of control, passivity, or made experiences. Note, these are all first-rank symptoms of schizophrenia. False belief that one's thoughts, feelings, actions, or impulses are controlled or made by an external agency. For example, believing that one was made to break a window by demons. Delusions of thought control include thought insertion, belief that thoughts or ideas are being implanted in one's head by an external agency. Thought withdrawal, belief that one's thoughts or ideas are being extracted from one's head by an external agency. Thought broadcasting, belief that one's thoughts are being diffused or broadcast to others such that they know what one is thinking. So let's get back to the text. Hints and tips. Note that the term paranoid refers to any delusions or ideas that are unduly self-referent, typically feelings of persecution, grandeur, or reference. It should not be used synonymously with the term persecutory. That means when a patient has a false belief that people are trying to harm him, do not say that he is paranoid. Rather, say that he has a persecutory delusion. So persecutory delusion, okay, that's more precise than, paranoid. Finally, beliefs that were previously held with delusional intensity but when become held with less conviction are termed partial delusions. This occurs when patients are recovering. Communication. Direct questioning about perceptual experience may alienate a non-psychotic patient and raise undue suspicion in a psychotic patient. To maintain rapport with patients, begin these questions with a primer such as I'm now going to ask you some questions which may seem a little strange, but are routine questions which I ask all patients. So let's talk about overvalued ideas. An overvalued idea is a plausible belief that a patient becomes preoccupied with to an unreasonable extent. So, a plausible belief that a patient becomes preoccupied with to an unreasonable extent. The key feature is that the pursuit of this idea causes considerable distress to the patient or those living around them. It means it is overvalued. That's why we call it overvalued, okay? Patients who hold overvalued ideas have usually had them for many years and typically have abnormalities of personality. They are distinguished from delusions by the lack of a gross abnormality in reasoning. These patients can often give fairly logical reasons for their beliefs. They differ from obsessions in that they are not experienced as recurrent intrusive thoughts. However, one will frequently encounter beliefs that span definitions. Typical disorders that feature overvalued ideas are anorexia nervosa, hypochondriacal disorder, dysmorphophobia, paranoid personality disorder, and morbid jealousy. This can also take the form of a delusion. Okay, we will talk about this later on. We have some tips to distinguish different types of abnormal thoughts in chapter 13. Okay, let's talk about thought disorder. Thought disorder is when someone's speech is so disorganized that it is difficult to follow what it meant. Okay? So thought disorder is when someone's speech is so disorganized that it is difficult to follow what it meant. Okay, what is meant? Again, thought disorder is when someone's speech is so disorganized that it is difficult to follow what is meant. Many patients with delusions are able to communicate in a clear and coherent manner. Although their beliefs may be false, their speech is organized. Thus, delusions are an abnormality of thought content, not thought form. However, there is a subgroup of psychotic patients who speak in such a disorganized way that it becomes difficult to understand what they are saying. The coherency of patients with disorganized thinking varies from being mostly understandable in patients exhibiting circumstantial thinking or being completely incomprehensible in patients with a word salad phenomenon. So let's see this figure that describes some of these disturbances. So this would describe normal thinking when you move from one idea to another to reach the point, from point A to point B, right from right here to right there, through the right path, and to the point. So association, goal directed. So goal directed, it is from A to B, and relevant associations, so it from one idea to another that is related to the other idea, and so on. While what we call circumstantial or over-inclusive thinking, it is less relevant. We have less relevant associations. Yes, we have some goal direction, the goal reached, but by circuitous route. So from A to B, yes, of course, but we reach that not directly, but rather we do some, going over there, here and there, and then to reach the point. This is circumstantial or over-inclusive thinking. While tangential thinking and to an extent flight of ideas, we have less relevant associations and the goal is never reached. Usually, if it is with normal speed, this is tangential. With accelerated speed, this would lead to flight of ideas. So from point A, not reaching the goal here, it reached here, and that in also this distraction. We have loosening of association with poorly unrelated concepts with unclear goals. So from this idea to this idea, and to this, from this idea to this idea, and so on. This is loosening of association. Describing the disturbance of a patient's thought from describing the disturbance of a patient's thought form is one of the most challenging tasks facing clinicians. This problem is compounded by two factors. It is impossible to know what patients are actually thinking. It means that thought form has to be inferred from their speech and behavior. The unfortunate situation has arisen where various authors in psychiatry have described a different conceptual view of thought disorder, which has resulted in conflicting and confusing classification systems. It is not essential to be able to identify all the subgroups of thought disorder, but it is important that you are able to say when thought form is or is not disordered. To describe the nature of the thought disorder, you should have a clear understanding of the individual definitions you intend to use. To help describe thought disorder, it is particularly helpful if you document and are able to cite examples of the patient's speech in their own words. Hints and tips. Many people have mildly disordered communication style, particularly when tired or stressed. Perhaps you can think of someone you know who is often mildly circumstantial in their storytelling. To count as thought disorder, the patient's thinking style should significantly impair effective communication. Okay. The following are important signs of disorganized thinking: circumstantial and tangential thinking, flight of ideas, loosening of association, which is called derailment, or night's move thinking. This is when the patient's train of thought shifts suddenly from one very loosely or unrelated idea to the next. In its worst form, speech becomes a mixture of incoherent words or phrases and is termed word salad. Loosening of association is characteristic of schizophrenia. Note that some psychiatrists, but not all, use the term formal thought disorder synonymously with loosening of association. Social forms of thought disorder. We have thought blocking. Thought blocking occurs when patients experience a sudden cessation to their flow of thought, often in mid-sentence, observed as sudden breaks in speech. Patients have no recall of what they were saying or thinking and thus continue talking about a different topic. Neologism. Neologisms are new words created by the patient, often combining syllables of other known words. Patients can also use recognized words idiosyncratically by attributing them with an unrecognized but related meaning. Metonyms, we call them. Perseveration. Perseveration is when an initially correct response is inappropriately repeated. For example, unnecessarily repeating a previous expressed word or phrase. Palilalia describes the repetition of the last word of a sentence. Logoclonia describes the repetition of the last syllable of the last word. Logoclonia. Perseveration is highly suggestive of organic brain disease. Echolalia is when patients senselessly repeat words or phrases spoken around them by others, like a parrot. Irrelevant answers is when patients give answers that are completely unrelated to the original question. So we are done with formal thought disorders. Let's talk about negative symptoms. Positive symptoms are those that are present when they should not be and include delusions, hallucinations, and thought disorder. In contrast, negative symptoms are abilities that are absent when they should be present and include marked apathy, poverty of thought and speech, blunting of affect, social isolation, poor self-care, and cognitive impairment. Patients can have positive and negative symptoms simultaneously, or, as often happens, develop a negative presentation after initially presenting with predominantly positive symptoms. Remember that patients with a depressed mood or those experiencing significant side effects from psychotropic medication may also present with what appear to be negative symptoms, which often presents a diagnostic challenge. Psychomotor function. Although a relatively rare phenomenon in industrialized countries, some patients with psychosis will present with abnormalities of motor function. Motor system dysfunction in schizophrenia is usually due to the extrapyramidal side effects of neuroleptic medication. However, patients with psychosis can occasionally present with striking motor signs that are not caused by psychiatric medication or a known organic brain disease, although undoubtedly associated with the patient's abnormal mental state. The cause of this psychomotor dysfunction is far from clarified. The term catatonia literally means extreme musculature tone or rigidity. However, it commonly describes any excessive or decreased motor activity that is apparently purposeless and includes abnormalities of movement, tone, or position. Note that catatonic symptoms are not diagnostic of schizophrenia. They may also be caused by brain diseases, metabolic abnormalities, or psychoactive substances, and can also occur in mood disorders. This table describes the common motor symptoms seen in schizophrenia. We have motor symptoms in schizophrenia like chronic rigidity, catatonic rigidity. Catatonic rigidity, maintaining a fixed position, and rigidity, resisting all attempts to be moved. That's obvious. Catatonic rigidity. We have catatonic posturing, which is adopting an unusual or bizarre position that is then maintained for some time. Catatonic negativism, a seemingly motiveless resistance to all instructions or attempts to be moved. Patients may do the opposite of what is asked. Negativism. We have catatonic waxy flexibility, or seria flexibilitas. Okay, flexibilitas. Seria flexibilitas. Catatonic waxy flexibility. Patients can be molded like wax into a position that is then maintained. We have catatonic excitement, agitated, excited, and seemingly purposeless motor activity, not influenced by external stimuli. Catatonic stupor, a presentation of akinesis, lack of voluntary movement, mutism, and extremely unresponsiveness in an otherwise alert patient. There may be slight clouding of consciousness. Echopraxia, patients senselessly repeat or imitate the actions of those around them, associated with echolalia. Also occurs in patients with frontal lobe damage. Echopraxia. Mannerisms, apparently goal-directed movements like waving, saluting, that are performed repeatedly or at socially inappropriate times. Stereotypies, a complex, identically repeated movement that does not appear to be goal-directed, like rocking to and fro, gyrating, and so on. Tics are sudden, involuntary, rapid, recurrent, non-rhythmic motor movements or vocalizations. So we are talking about patients with psychotic symptoms. So what about differential diagnosis? Psychotic symptoms are non-specific and are associated with many primary psychiatric illnesses. They can also present secondary to a general medical condition or psychoactive substance. Here we have a book that describes the differential diagnosis for psychotic symptoms. The differential diagnosis for psychosis is psychotic disorders like schizophrenia, schizophrenia-like psychotic disorder, schizoaffective disorder, or delusional disorder. Mood disorders like manic episode with psychotic features or depressive episode severe with psychotic features. It could be secondary to general medical condition or secondary to psychoactive substance use. It could be these psychotic symptoms because of dementia or delirium, Personality disorder like schizotypal personality, borderline personality, schizoid or paranoid personality, or because of neurodevelopmental disorders like autistic spectrum. So let's talk about these differentials. Psychotic disorders. Start with schizophrenia. There are no pathognomonic or singularly defining symptoms of schizophrenia. It is a syndrome characterized by a heterogeneous cluster of symptoms and signs. The International Statistical Classification of Diseases and Related Health Problems, the 10th edition, has set out diagnostic guidelines based on the most commonly occurring symptom groups, which have been discussed in the preceding section. It is also important to establish that there has been a clear and marked deterioration in the patient's social and work functioning. In the past, psychiatrists used Schneider's first-rank symptoms to make the diagnosis of schizophrenia. Kat Schneider suggested that the presence of one or more first-rank symptoms in the absence of organic disease was of pragmatic value in making the diagnosis of schizophrenia. First-rank symptoms are still referred to, so you should familiarize yourself with them. They are presented in the books. We've talked about them, and actually they are not used anymore in DSM-11. So, but to remind ourselves with them. So these are the guidelines for schizophrenia. One or more of the following symptoms: thought echo, insertion or withdrawal, delusions of control or passivity, hallucinations, voices. These are, Schneiderian first-rank symptoms. So I will not actually bother myself with them, but to remind ourselves of these first-rank symptoms: delusions of delusional perception, delusions of thought control, delusions of control, and hallucinations. Okay, so let's continue with that. Okay. Here we have hints and tips. Memory aid. If you add bizarre delusions and hallucinations coming from a part of the body to Schneiderian's first-rank symptoms, you will have the A to D criteria of ICD-10 diagnostic guidelines for schizophrenia. Okay. Schizophrenia subtypes. Due to the differing presentations of schizophrenia, researchers have tried to identify schizophrenia subtypes. The importance of these subtypes is that they vary in their prognosis and treatment response. Actually, they are not. At least that's what studies show recently. So let's just read about that, because in ICD-11 I think they are not there. And of course in the DSM-5 they are not there also. So, okay, the ICD-10 has coded the following subtypes, which are not necessarily exclusive. Paranoid schizophrenia, dominated by the presence of delusions and hallucinations, positive symptoms, negative and catatonic symptoms, as well as thought disorganization, are not prominent. Again, dominated by the presence of delusions and hallucinations, positive symptoms. Negative and catatonic symptoms as well as thought disorganization are not prominent. The prognosis is usually better and the onset of illness later, typically 18 to 25 years, than the other subtypes. Okay, we have hebephrenic schizophrenia, which is disorganized schizophrenia, characterized by thought disorganization, disturbed behavior, and inappropriate or flat affect. Delusions and hallucinations are fleeting or not prominent. Onset of illness is earlier, 15 to 25 years of age, and the prognosis poorer than paranoid schizophrenia. We have catatonic schizophrenia, a rare form characterized by one or more catatonic symptoms. We have residual schizophrenia, 1 year of predominantly chronic negative symptoms which must have been preceded by at least one clear-cut psychotic episode in the past. We have schizophrenia-like psychotic disorders. Some psychotic episodes with schizophrenia-like symptoms seem to have an abrupt onset, without a prodromal phase, precipitated by an acute life stress, or to have a shorter duration of symptoms than that usually observed in schizophrenia. The ICD-10 codes these as acute and transient psychotic disorders. So again, here we are talking about ICD-10, but nowadays we have something called ICD-11. So we should actually familiarize ourselves with DSM-5 and ICD-11 subtypes, not these. So, for example, for schizophrenia or other primary psychotic disorders, yes, of course, we still have this acute and transient psychotic disorder. To remind you, in DSM-5 we have brief psychotic disorder and somatoform, schizophreniform disorder. Okay. Here they will talk about that. Okay, the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, on the other hand, suggests diagnoses of schizophreniform disorder and brief psychotic disorder. Often these diagnoses are superseded by a later diagnosis of schizophrenia as the clinical picture evolves. So what about schizoaffective disorder? Schizoaffective disorder describes the presentation of both schizophrenic and mood, depressed or manic symptoms that present in the same episode of illness, either simultaneously or within a few days of each other. The mood symptoms should meet the criteria for either a depressive or manic episodes. Patients should also have at least one, preferably two, of the typical symptoms of schizophrenia. Okay. Depending on the particular mood symptoms displayed, this disorder can be coded in the ICD-10 as schizoaffective disorder manic type or schizoaffective disorder depressed type. Here we have some hints and tips. When psychiatrists talk about the typical symptoms of schizophrenia, they are generally referring to points A to D of ICD-10 criteria for schizophrenia, or Schneider's first-rank symptoms, delusions or control of running commentary, hallucination, etc. Okay. Delusional disorder. In this disorder, the development of a single or set of delusions for the period of at least 3 months is the most prominent or only symptom. It usually has onset in middle age and may persist throughout the patient's life. Delusions can be persecutory, grandiose, and hypochondriacal. Typically, schizophrenic delusions such as delusions of thought control or passivity exclude this diagnosis. Hallucinations, if present, tend to be only fleeting and are not typically schizophrenic in nature. Brief depressive symptoms may also be evident. Affect, speech, and behavior are all normal, and these patients usually have well-preserved personal and social skills. Rarely, patients may present with an induced delusional disorder, folie-à-deux, which occurs when a non-psychotic patient with close emotional ties to another person suffering from delusions, usually a dominant figure, begins to share those delusional ideas themselves. The delusions in the non-psychotic patient tend to resolve when the two are separated. So another differential mood or affective disorders, we will talk about the manic episode with psychotic features, depressive episode severe with psychotic features. Okay. Another differential, psychotic episodes secondary to a general medical condition or psychoactive substance use. A medical or psychoactive substance cause of psychosis should always be sought for and ruled out. Here we have a box that lists the medical and substance-related causes of psychotic episodes. We've talked about that, yeah, of course. Okay, but let's just, medical and substance-related causes of psychotic symptoms. Medical conditions like cerebral neoplasm, infarcts, trauma, infection, inflammation, including HIV, CJD, neurosyphilis, herpes, encephalitis. Okay. Endocrinological causes like thyroid, parathyroid, or adrenal disorders. Epilepsy, especially temporal lobe epilepsy. Huntington's disease. SLE, vitamin B12, niacin, and thiamine deficiency. B12 deficiency, niacin, which is pellagra, and thiamine deficiency, which is vernix encephalopathy. Acute intermittent porphyria. Substances like alcohol, cannabis, novel psychoactive substances, amphetamines, cocaine, hallucinogens, inhalants, solvents. Prescribed drugs like antiparkinsonian drugs, corticosteroids, and anticholinergics can cause that. The medical condition or substance use should predate the development of the psychosis, and symptoms should resolve with treatment of the condition or abstinence from the offending substance. Although sometimes exposure to a recreational substance can precipitate a psychotic illness which never resolves. Absence of previous psychotic episodes and absence of family history of schizophrenia also supports this diagnosis. Another diagnosis, delirium and dementia. Visual hallucinations and delusions are common in delirium and may also occur in dementia, particularly diffuse Lewy body dementia. Personality disorder. In general, schizophrenia presents with a clear change in behavior and functioning, sometimes with a prodrome. Whereas in patients with a personality or neurodevelopmental disorder have never achieved a normal baseline. Schizotypal personality disorder is characterized by eccentric behavior and peculiarities of thinking and appearance. Although there are no clear psychotic symptoms evident and its course resembles that of a personality disorder, the ICD-10 actually describes schizotypal disorder in the chapter of psychotic disorders. This is because it is more prevalent among relatives of patients with schizophrenia, and occasionally it progressed to overt schizophrenia. Borderline, paranoid, and schizoid personality disorders also share similar features to schizophrenia without displaying clear-cut psychotic symptoms. Personality disorders are discussed in greater details in chapter 17. Neurodevelopmental disorder. Another differential. Social difficulties and rigid thinking are found in both autistic spectrum disorders and schizophrenia. So we have this algorithm for the diagnosis of psychotic symptoms. So if we have psychotic symptoms, we look if they are secondary to medical condition or psychoactive substance use. If yes, so organic psychotic disorder or substance-induced psychotic disorder is the diagnosis. If no, we look for the duration. If it is shorter than 1 month, so it is schizophrenia-like psychotic disorder, acute or transient psychotic disorder. In the DSM-5, we call it brief psychotic disorder. If not, if the presence of delusions only and the duration is longer than 3 months, so this is delusional disorder. But of course, in DSM-5, it's not it's just 1 month, for delusional disorder. And we have another option other than brief psychotic disorder. If the duration is from 1 month to 6 months, this is schizophreniform disorder. Anyways, if no, typical schizophrenic symptoms and in the absence of prominent mood symptoms, depression or mania, if this is the case, so here we are talking about schizophrenia. In DSM-5, it takes 6 months to diagnose. The duration to be 6 months or more. If no, and we have schizophrenic symptoms In the presence of prominent mood symptoms, so we are talking about schizoaffective disorder. If no, and the psychotic symptoms usually mood congruent in the presence of prominent mood symptoms, this is depression with psychotic features or mania with psychotic features according to the case. For the assessment, starting from history, the following questions may be helpful in eliciting psychotic phenomena on mental status examination. About hallucinations. Do you ever hear strange noises or voices when there is no one else about? Do you ever hear your own thoughts spoken aloud such that someone standing next to you might possibly hear them? Audible thoughts, first-person auditory hallucinations. Do you ever hear your thoughts echoed just after you have thought them? Thought echo. Do these voices talk directly to you or give you comments? Second-person auditory hallucinations. Do these voices ever talk about you with each other or make comments about what you are doing? Third-person auditory hallucinations or running commentary. How we ask about delusions. You ask like this. Are you afraid that someone is trying to harm you or poison you? Persecutory delusions. Have you noticed that people are doing or saying things that have a special meaning for you? Delusions of reference. Do you have any special abilities or powers? Grandiose delusions. Does it seem as though you are being controlled or influenced by some external force? So this is about delusions of control. Are thoughts that don't belong to you being put into your head? This is thought insertion. It's important to obtain collateral information from the patient's GP, family, and any other mental health professionals involved in their care to establish premorbid personality and functioning, as well as pattern of deterioration. Examination. A basic physical examination, including a thorough neurological and endocrine system examination, should be performed on all patients with psychotic symptoms. Investigations. Blood investigations are performed to exclude possible medical or substance-related cause of psychosis, establish baseline value for administering antipsychotics and other psychotropic drugs, assess renal and liver functioning, which may affect elimination of drugs that are likely to be taken long-term and possibly in depot form. If the patient presents with a first episode of psychosis, a good basic screen comprises full blood count, erythrocyte sedimentation rate, urea and electrolyte, thyroid function, liver function, glucose, lipids, serum calcium, and serology for any suspected infections. A urine drug screen should always be done because recreational drugs both cause and exacerbate psychosis. An electrocardiogram should be done in patients with cardiac problems, as many antipsychotics prolong the QT interval and have the potential to cause lethal ventricular arrhythmia. The use of routine electroencephalogram, computed tomography, or magnetic resonance imaging scan to help exclude an organic psychosis like temporal lobe epilepsy or brain tumor varies between psychiatric units. They should always be considered in atypical cases with treatment-resistant, or if there are cognitive or neurological abnormalities. So, at the end of this chapter, let's discuss the case that we've read at the first of this chapter, so you can remind yourself of that. So, okay, Mr. PP meets the ICD-10 criteria for schizophrenia, paranoid type. He has had a marked deterioration in his social and work functioning. He has delusions of persecution, believing he was a victim of government experiments. Thought control, believing that ideas were being planted in his head. Thought insertion. And reference, believing that the man in the pub was referring specifically to him. His claim that he knew these things after hearing the neighbor's dog bark suggests delusional perception. He also has second-person command hallucinations and third-person running commentary hallucinations. Receiving coded information from the radio might be a hallucination or a delusion of reference, depending on how Mr. PP described this experience subjectively. Mr. PP's description that all was not right could indicate the presence of a delusional atmosphere prior to the development of the full-blown delusions. It is imperative that a substance-induced psychotic disorder or psychotic disorder secondary to a medical condition is excluded. It would be important to ascertain the duration of Mr. PP's psychotic symptoms. It seems as though he has had schizophrenic symptoms for over a month. If the duration of symptoms had been less than a month, it would be advisable to diagnose a schizophrenia-like psychotic disorder, acute and transient psychotic disorder. It is important to rule out a mood disorder with psychotic features. The presence of mood episode associated with simultaneous schizophrenic symptoms would suggest schizoaffective episode. Prominent hallucinations militate against a diagnosis of delusional disorder. Now you can go on to chapter 21 to read more about psychotic disorders and their management. So, chapter summary. Psychosis is when the experience of reality is grossly distorted. Psychotic symptoms comprise delusions, hallucinations, and thought disorder. A delusion is a fixed false belief which arises through faulty reasoning, is not altered by evidence to the contrary, and is outside cultural norms. A hallucination is a perception in the absence of a stimulus. Thought disorder is speech so disorganized that communication is impaired. When assessing someone with psychotic symptoms, explore the nature and content of their abnormal experiences, their signs and symptoms, how these symptoms are affecting them and their current and past social circumstances, functional impact. You assess also their physical health and use of recreational substances, and obtain a collateral history from someone who knows them well, as lack of insight can prevent the patient giving a full history. The key differentials for someone presenting with psychotic symptoms are schizophrenia, mania with psychotic symptoms, drug-induced psychosis, and psychosis secondary to a general medical condition. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.